So good evening everyone. Welcome back to the module. So I'm going to talk about groin injuries and rehabilitation. As a physiotherapist, it's very difficult to understand, very difficult to treat. It's very challenging in the field of sports physiotherapy. It's called groin injuries. So when we have a patient with the groin injuries, we tend to spend a lot of time in diagnose the condition. Also, it's one of the main responsibility to send the player back, return to play. So it all depends on the diagnosis as well as the rehabilitation plan that we are going to make for the player to return to play. It's a challenging one, as I said, in the sports physiotherapy. Let's move on to the main topics. The learning outcome of the topic. At the end of the sessions, you will be able to understand the mechanism of groin injury in sports, and you'll be able to understand the significance of surface anatomy of groin region, and you will be able to develop a rehabilitation program for groin injuries. Before we move on to the diagnosis and then rehabilitation, we should know where is the groin. So where do you identify the groin area if someone is presenting to you with the groin pain? So we should have explanations, and then we should be aware of the site of pain. So the site of pain here is the groin. So where is the groin? Do you have any idea? Alright, let's see where is the groin. So here, in the year of 2015, the Falvey et al. Described clinically the groin as a inguinal region at the junction of the abdomen and the thigh. So mostly in the athletic populations, chronic pain and an injury in the groin area commonly presents in multi-directional sports, including soccer. So if you talk about the groin triangle, so what do you mean by groin triangle? So the groin triangle is made up of anterior superior iliac spine, 3G point called the point midway between the ASIS and the upper pole of patella, the tensor fasciae latae, pectineus, iliopsoas, adductor longus, gracilis, serratorius, and then rectus femoris, vastus lateralis, and then vastus medialis. So this is all about the groin triangle. So why should we know about the anatomy? So basically, the Falvey et al. Is aimed to describe the clinical presentations, physical examinations, along with the MRI findings, and then the passive range of movement of a joint in athletes presenting to a secondary and tertiary referral clinic with athletic groin pain. Now, let's discuss about the Falcon's perspective by Adam Weir. So the most common groin injury in athletes is because of adductor related. Usually, as described by the Falcon's perspective, it's weird and it's very difficult because it's a mammoth, it's abundance of causes for groin pain. So, as discussed by Adam Weir, the adductor related groin pain in both, especially in acute as well as long standing, the most common groin injury as described by Halmik et al. As we are all aware that there are different adductor muscles. We have adductor longus, adductor brevis, adductor magnus, gracilis, pectineus, as we seen in groin triangle, and obturator externus. In that, adductor longus is the vast majority of groin injuries affects, as described by Cernel et al. So the adductor longus muscle is the majority of the cause for groin pain in athletes. Now, let's have a deep discussion about a muscle. It's called adductor longus. So the adductor longus, role of adductor longus, it acts as a hip adductor. Also, it acts as a synergist in hip flexions when the hip is in extension. It is a hip flexor when the hip is in extension. And it works hard eccentrically to turn the hip extension into flexion, which is a part of many athletic movements, which obviously you could see in sport called soccer. If you are really aware of the anatomy of the adductor longus, if you look at the picture on my right hand side, the entire proximal tendon becomes intramuscular at about 5.5 to 8 centimeter from the insertion, where it continues as an intramuscular tendon. So the length of the total length of the adductor longus between 7 and 17 centimeter, while long-standing adductor groin pain is usually related to the insertion. So in both acute and long-standing adductor related groin pain, usually the pain present at the proximal insertions is considered to be the most severe, whereas the long stand, in order to do a differential diagnosis, usually long-standing adductor groin related pain usually related to the insertions, whereas pain at the proximal insertion is considered to be the most severe. Now, iliopsoas. So what is iliopsoas? So the iliopsoas comprised of psoas major and then iliacus, as we are all aware that those are the powerful hip flexors. It can function as a unit or intervene as a separate functions. And also we should know about inguinal canal, because already we studied in the anatomy. As we discussed, what is the reason to know about the inguinal canal? Because so when we talk about where is the groin, so the groin is the junctional part between the lower abdomen and the thigh. So the inguinal canal also can cause groin pains. That's called inguinal related groin pain. So the inguinal canal is presented in the lower anteromedial and then abdominal wall, just above the inguinal ligament. And then obviously we should know what are the structures that pass through the inguinal canal. What are the main structures that pass through the inguinal canal? The number one is ilioinguinal nerve, genitofemoral nerve, it's a branch of the genital, spermatic cord in men or around the ligament in women, and accompanying vessels. And the superficial inguinal ring is just above the pubic tubercle and is the medial end of the inguinal canal. The inguinal canal represents the opening of inguinal canal in the external oblique fascia, and then we can palpate the ring through the abdominal wall in athletic subjects. Next one is pubic symphysis. The pubic symphysis is a non-synovial joint lined with the hyaline cartilage, and it contains a fibrocartilaginous disc. In athletes, in sporting populations, the pubic symphysis undergoes a considerable mechanical stress. So it's purely because of the sports. And then following the mechanical stress, the joint may be a source of pain, including the adjacent bone. So obviously you could have seen a lot of sporting populations with the groin pain, but so if you talk about the pubic related groin pain, is one of the least frequent clinical entities in adult athletes. It's very rare in terms. And it is very important to note that the public, it is very important to note that the pubic apophyses are one of the last areas in the body to ossify, only fully fusing around 20 years of age. There is a growing attention that groin pain and the adductor incisions on the pubic bone in athletes in the age of 14 to 19 is often pubic apophysis. This should always be considered as a potential differential diagnosis in adductor related groin pain in young athletes. So it's important to know about what are the structures that can cause possibly a groin pain in injury athletes. So in further slides we'll get to know why do we read about pubic symphysis, inguinal canal, iliopsoas, and then adductor related groin pain. Now it's a time to move on to the next slides. How do we diagnose the conditions? So if sportsman walks into a clinic and saying that I have a groin pain, then how do you diagnose it? So are you diagnosing through obtaining a patient's history, kind of hypothesis generations, or by doing a clinical examinations? Or even if you have time and then even more money, will you be able to do ultrasound and then try to find out with the help of sports medicine physician? Or still, like, if you can go far beyond, and then will you be able to do a magnet MRI? Yes. How do we diagnose it then? So the diagnosis can be made by following the simple steps. Always when a sporting athlete or a population presents to you with a groin pain, always we should look at the general diagnostic overview. So what possibly can obtain from a patient? What is the diagnostic overview? And then again, as you said, like, can we trust the detailed MRI scoring? Because if the patient carries MRI with you, and then as we discussed in the previous slides, like once we how do we diagnose the groin pain, or through a history, or by doing a clinical examinations with the help of sports medicine physicians, or do we rely on the MRI? Yes. So once you obtain the general diagnostic overview, we can also look at the MRI scoring, and then again we will be able to do the clinical examination test, and then if there is any correlations, again you can look at the MRI. And definitely, can we trust our clinical examination test with the help of sports medicine physicians? And then you go back and then reassess and then reconfirm with the MRI, and then also you'll be able to find, is there any specific injury characteristics? Yes, there are specific injury characteristics. Let's look at in the next slides. Now, so before we complete this slides, we'll just have a quick review. So we were talking about anatomy, where's the groin, and then we also discussed about Falcon's perspective by Adam Weir, and then we just studied about a little bit of anatomy of a region called adductor longus, iliopsoas, inguinal canal, and pubic symphysis. And then we did slightly talk about diagnosis. How do we diagnose the groin pain, and what are the studies on diagnosis? How do we diagnose the acute groin injuries?